This video will discuss tips and techniques for endovenous laser ablation. This procedure is rapidly becoming the industry standard for the treatment of saphenous vein incompetence. It can be performed on both the greater saphenous vein and the small saphenous vein. It can also be performed on any significant subsurface segment that is implicated in the surface pathology as long as that segment meets certain criteria for treatment. Successful access is critical to the procedure. Percutaneous access is advantageous, but some clinicians prefer to perform a cut-down and exteriorize the vessel. The next step is precise and accurate placement of the catheter and laser fiber. The final step before delivering the laser energy is effective anesthesia. Probably the most critical step in the procedure is patient selection. Certain criteria should be met. Make an assessment as to whether the guide wire will pass without difficulty to the saphenofemoral junction. Different clinicians have different skill levels. Make certain the vessel matches your technical capability. Veins that are very close to the surface are probably better off removed with the hook phlebectomy technique. Another important decision to make is the minimum size and length vein segment that should be treated. The exception to this would be the small saphenous vein because the laser provides a more precise and controlled injury in an area where ultrasound-guided sclerotherapy can prove hazardous due to the proximity of the small saphenous vein to the deep veins. The setup should include the necessary needles and syringes for administration of anesthetic, irrigation of the catheter, and of course the specific items and instruments needed for the procedure. However, if at all possible, do not sacrifice significant treatment length in favor of ease of access. It is best to ablate as much length of the abnormal vein as is practical, just prior to penetration. This is a valuable maneuver and is easily learned by anyone with good ultrasound skills. A vacuum technique using a 1 cc syringe attached to the introducer needle is another helpful tip. The next step is to place and properly position the sheath and laser fiber. A pistol-type configuration, as seen here, often marks the saphenofemoral junction, but in the longitudinal view, the pistol sign is obvious. Most of the time, on initial insertion, the sheath is passed well beyond the junction into the femoral vein. It is a good idea to secure the sheath to the skin with steri-strips. If the sheath gets moved during the course of giving anesthesia, it can be difficult to reposition it in a precise location due to the tissue distortion that normally occurs from giving the anesthetic. Anesthesia is started at the catheter tip. After administering the anesthesia, view the vein and catheter in the transverse mode. The final step is to fire the laser.